Got some people starting to trickle in here. I'm gonna give it a give it another 30 seconds or so, maybe another minute. For those of you who are joining us and coming on, to get us started, if you could post who you are and where you're coming from in the chat, we'd love to get to know you a bit more and know about where you're from. All the introductions and stuff.
Slowly popping in.
Well, I think it looks like the influx has stopped, so I think we can go ahead and start up. Welcome everyone to our webinar today regarding health concerns and some triggers in the news. I'm Dr. Jason Gibbs. I'm a licensed clinical psychologist here at NOCD. I will be helping out with the presentation today, review some things, and answering any questions that you guys may have as well. I'm also joined by Mackenzie, who I will go ahead and introduce herself now.
Yeah, hi, I'm Mackenzie. I host support groups for NOCD, and I also went through exposure response therapy with NOCD as well. So I have had OCD my entire life. It's awesome. Just kidding. But yeah, happy to be here and happy to answer questions.
Awesome. Thank you so much for that, Mackenzie.
Yeah.
For today's webinar, guys, we are going to dive right into this topic. Probably go around, I don't know, 20, 30 minutes. We'll kind of see how it flows. Any questions? And I'm sure there will be plenty that come up. And we're going to allot a lot of time for the questions at the end. We're going to ask you to put them in the Q&A section of your Zoom. So if you open the Zoom window, it'll be, at least on my end, it's to the left of the chat option and to the right of the participants button. So any questions can be placed there, and we will review those at the end. That's the way that you'll be able to communicate with us on this topic. I don't think there's any other major things. Anything else, Mackenzie, that we should review before we dive on in?
No, I don't think so. Yeah, just remember to not put them in the chat and make sure we put them in the, yep. Jason just said that, but reiterating.
No, that's really good. Had I not been told that before we started, I probably would have done the same thing. So you have any questions you have, just put in the Q&A section, and we will get to those here at the end. So to get us started, want to talk about part of the reason we're having this is there's a lot of things that are going on in the news now related to health concerns, but I would say this is to at least a lesser degree, always a concern in our society with 24/7 news and information going around about the newest illness or virus breaking out in some part of the world. Hot topics right now are things like the bird flu, measles, food safety. COVID has obviously been a thing for a number of years. There's even some stuff out there regarding microplastics. CDC funding has been a big topic in the past month or so. Basically, a lot of stuff that comes up in our on the news, on what do the kids listen to nowadays? The Reddit,
Social
the
media.
social media stuff about all these things you have to be concerned and anxious about. Again, always there, but a lot of stuff going on recently around it. And it can, in the best of circumstances, I think, be difficult to know what is a true quote unquote threat, what is dangerous, and what is not. When you are somebody who struggles with symptoms of anxiety and or OCD, that becomes doubly difficult and confusing. And it can be really hard to know, are these anxieties, these thoughts that I'm having, these worries, whatever you want to call them, are they legitimate things that I and everyone else should be worried about? Are they completely irrational and something that is pathological? Is it somewhere in between? Is there some legitimacy to that? This is there some anxiety? Um, and these are right. There are a few strategies that you can use though that can really help you to understand is what do I do with this information? To give you an example, just because it's one I think we're all familiar with, regardless of how much we watch the news, because we all lived it for at least a year or so in our homes, is COVID. Uh, Huge issue a few years ago, but there's new strains that come out every year. There's talk about, is this one more dangerous or less dangerous? And there are real health risks associated with this, right? A lot of the recommendations for things like COVID are stuff such as actions such as you should avoid being around people, wearing masks, social distancing, washing your hands. And as some of you may know, these are very common symptoms of OCD. People will wash their hands for hours on end. They don't feel clean. They'll refuse to go outside. Things that, to a degree, the CDC has recommended in the past. So how do you know? How do you know if this is an OCD or anxiety thing or something you should really be doing? There are a couple of rules and guidelines that I really like to recommend, although I'd love to hear from Mackenzie's learned experience with this as well.
Yeah.
A couple of the things that I always tell people is one, if you let's say that you have this concern about COVID and you're telling somebody when you're going to wash your hands, when you're going to, how much you're going to isolate from people. Would the average person the average reasonable person that you know out there in society look at you and say, that makes sense? Or would they be like, wow, that is overkill. That's not something that other people are doing. What is the normalcy of it? And normalcy I know is a loaded word, so it might be better to say, what is the more common thing that you would see people doing? As an example, it is not common for somebody without OCD to touch a doorknob and wash their hands intensely with soap and water. But if they fell in dog poop, they would wash their hands with soap and water. And a similar thing with COVID. Would other people wash their hands if exposed to this type of COVID situation? So if somebody with COVID coughed on them, they would probably go and try and cleanse it off. But if they saw somebody from a block away cough, they would probably not feel the need to cleanse themselves. What are other people doing? The other heuristic that I use is to recommend that you ask yourself, how many times are you doing the safety behavior, the thing to make sure you're clean, in this case, that you're not sick? People without OCD who are engaging in proper safety and cleansing practices will generally do something once, and that is it. Oh, I got this contaminant on me. I'm going to go and wash my hands. I feel better now. That's it. There's not a need to come back and do it later. With OCD, it is defined as something with repeated compulsions that either do not make you feel better or only make you feel better temporarily. So are you washing your hands once because something got on you, whether it's COVID or feared measles contamination, or are you washing your hands over and over again? Are you doing it for hours under scalding hot water? What is the frequency and intensity of this? Mackenzie, I'd love to hear your insights on this too. What are some things that you think can kind of help people to identify when health concerns become more an obsession?
Yeah, I think so. When I started ERP therapy, I used my husband as like a baseline. And so that was kind of where I started, like kind of with what you're saying, right? Like what would a neurotypical or someone who wasn't struggling with OCD, what would be that normal? And I think now what I do, I always tell people in groups, I think for me, I recognize that there's a healthy level of concern. And then there's when my OCD joins the group chat. And I think, having that self-awareness and saying, okay, like, washing my hands once is a healthy level of concern. Now I'm washing it 3 times and, I'm asking if everyone else washed their hands. Okay, my OCD has probably entered the group chat. And I think that if and when we give in to a compulsion, it's also important to be kind to ourselves and have a lot of self-compassion because it is going to happen. Oh, OCD is with us for the long haul, but it's extremely manageable and treatable. And so I think, we're not always going to get it exactly right. And I think, especially with OCD, we sometimes get stuck on, is this for sure a compulsion or, is this not? And I think it's doing our best and doing our best to be aware when we've kind of passed over that threshold of a healthy level of concern.
And one thing Mackenzie said that I like and really want to emphasize is that when you have OCD, you might already know this, even without OCD, you know, you're gonna have in times of stress when there is a lot of stuff going on, you're gonna be without OCD more anxious. And if you have OCD, it's more likely you're gonna have symptoms flare up. And nobody resists 100% of their compulsions. Nobody. I've never met anybody who does it. And that's okay. You might notice that you go down a bit of a rabbit hole and spend an hour researching on something that you don't need to. While it's good to identify these things and figure out ways that you can help to ward them off in the future, because as we know, that can sometimes make symptoms worse, it's not something to get down on yourself. Not at all. This is going to happen during these times. I mean, it's your arguably greatest or one of your greatest fears coming true in the world, so it's understandable symptoms would come back up. And on that note, if symptoms do come up, it doesn't necessarily, some people hit the panic button. Oh my gosh, I'm worrying about my health again all the time. Do I need to seek out help? Do I need to get treatment? And just because you have a flare-up in symptoms doesn't necessarily mean that you need that. There's a lot of factors involved. If you're someone who's gotten treatment for OCD in the past and you know what to do, it might be just a matter of bringing back in those skills that you've learned from treatment before to navigate this new situation. Often, even if you haven't received treatment and you have more obsessive worries or thoughts or neurodivergent responses to these specific triggers, it still doesn't necessarily mean you need treatment. Sometimes we have these life stressors that come and go, and things get worse for a little while, but then things get better as time passes and we move on. When we often recommend treatment and support is when this really starts to go on for quite a while, from several weeks in, several months, and or the intensity is getting to the point where it's not letting you function. This would be if it's starting to get hard to go to work, to go to school. You're realizing you're having to call off, or maybe you're managing to get through those things, but in the case of COVID, for example, you have a fear of COVID. Maybe this is a mild strain. You're vaccinated, others are vaccinated. and yet you're still so anxious you refuse to leave the home. And it's interfering with your ability to go out and be with your friends and family and loved ones. Those are times where, especially if you haven't received treatment for these types of presentations, it can be helpful to reach out and get support. And the important thing for these types of fears is, first and foremost, wherever you go, you don't want to assume you know what it is. There are a lot of different ways that fears over health concerns manifest. Sometimes it can be what's called obsessive compulsive disorder, other times what's called illness anxiety disorder. It could be symptoms of generalized anxiety disorder. We're only kind of scratching the surface. There are several things, and depending on what it is, the treatments for them differ. And so you want to first make sure you go to somebody who is not just going to give you a cookie cutter response or treatment for this. The treatment that we use for OCD can be significantly different than the treatment we use for generalized anxiety disorder in many cases. Treatments that work for worries do not work for obsessions and OCD, and in fact can make them worse. So you want to arrive at that proper diagnosis. Once you've been able to identify what it is, if it is even anything, you might find that the person you go to says, hey, sounds like you're just experiencing a little bit of increased anxiety and maybe you just need some time off from work. It might not even be anything that we would give a quote unquote label to. But if it is something, especially something like OCD, one of the more kind of nuanced disorders, in my opinion, you want to make sure that you go to somebody who knows specifically how to treat that. Most providers are skilled in treating presentations of things like generalized anxiety disorder. This is when you just have worries over a bunch of things. Am I going to be healthy? Am I going to make it to work on time? Am I going to be able to pay the bills? With OCD, these are those intense images of just terrible things happening from these illnesses, and you're engaging in specific and repetitive things like hand washing or researching online for hours and hours on end. This is a type of treatment where both from a therapy and medication side of things takes more specialized training. So from the therapy side of things, you want to, at least what we can speak to, you want to make sure that you go to a practitioner who is trained to treat OCD, and the gold standard treatment for that being exposure and response prevention. Most providers who will list what they treat on their website or profile page. The one thing I always kindly caution people over is there are people out there who will say, oh, I treat OCD, but they will list their specialty on their webpage and they'll have like 30 specialties. I treat OCD, GAD, pica, early onset, made up word. They will say they list and they treat everything. You want to be, not that they may not, they may be around for a while and trained in everything, but you want to be careful. In my experience, you want to be careful of those. You want to look for somebody who says, hey, I have specialized training in these several areas. And you want to specifically look to make sure that they list that they do exposure and response prevention. Again, that's the gold standard treatment for OCD and the one that is going to be the most help in these circumstances. For medication side of things, generally we're recommending more. I always recommend people go to a psychiatrist or an APNP in these cases versus a general practitioner or a physician's assistant, as the APNPs and psychiatrists will have more knowledge in this area. Mackenzie, I think you were gonna say something maybe?
Oh, yeah, well, I was just gonna say too, I think kind of going back to knowing when health concerns become obsessive, which you were talking about. I think so. My core fear, which I identified in ERP therapy, is death. And I was so afraid of dying that I wasn't living. And that was my kind of like aha moment. And, what is the point of being afraid of dying if you're not living at all? And it definitely became, you know, um, completely overwhelming and all consuming. And I will die on the hill that OCD is a family disorder because it affected so many of my loved ones and my friends. And I always say with my contamination OCD, like even the cashier, the poor cashier at the grocery store, it affected everyone. Because I was always scanning for danger, and everyone in
Mhm.
group, I always laugh the little blue band-aids that they wear when there's like a cut. I'm like, oh no. So yeah, I think when I couldn't get out of my own way, and I wasn't functioning. And that was, kind of reiterating what you were saying too, like when we're not participating, we're not leaving our house, all of those things. And I think the really cool thing about exposure response therapy is learning to let your values push you, and guide you through versus your fears. And so that was really a really neat thing to learn.
Yeah, I love that, Mackenzie, and I appreciate you sharing. OCD is going to take away a lot from our life. It's ironic in my experience, ironically, by engaging in OCD, the thing that we're afraid of often is more likely to happen. I've worked with a lot of people who are so afraid of contamination that they wash their hands till they're raw and bleeding, and they're more likely to get infections.
I got it.
Um,
That was what happened. Yeah. Me.
oh yeah, it's it's very common, and it's just kind of goes to show the hold that OCD can have on you. Good news is, although it does take people here specialized treatment, they think it means, oh, it's like success rates are low. It's actually very treatable. Just it's one of those things that for whatever reason, not as many people out there know how to treat. But when you do find someone who knows how to treat it, if you're able to go and do the work, it can work very, very well.
Yeah, I think a cool thing about ERP therapy too was no one sat me down and said like, "Oh, you're going to learn to be self-confident and you're going to learn self-awareness," and you inadvertently do, and those are like two of my biggest tools that I took away from that because, having that self-awareness to say like, "Okay, OCD has entered the group chat. Like, what are we going to do now?"
Yep.
And being confident in our ability to navigate through uncertainty. And um I think, you know we have to learn to manage OCD in the best of times and the worst of times. And I it's one of those things where if something bad happens in life, it's not because OCD was right, it's because it's life. And things happen.
Exactly. Exactly. Well, I think that covers our the main part of the presentation here. Kind of looking at time, we wanted to allot about 30 minutes or so for questions. For those of you who may have joined us a little bit in, if there are any questions related to this where so we don't have the option to kind of hear you verbally, we're asking that you open up the Q&A portion of the Zoom call and submit your questions there, not the actual normal chat function, but the thing that says Q&A. And on that note, I figured we'd open up and go through some of these. First one on here, you mentioned OCD versus illness anxiety disorder. Can you elaborate on how to differentiate between these diagnoses and how the treatment would differ? For sure. So illness anxiety disorder and OCD from uh, a lot of the disorders, it is very important to differentiate between OCD and GAD is a big one. OCD and depression, huge one. OCD and illness anxiety disorder, it becomes more of a question of the name that you're giving to it. The way that illness anxiety disorder presents is very similar to OCD. You have the equivalent of obsessions and compulsions in illness anxiety disorder. It's a anxiety distress-based response where you are concerned that you may have an illness and you are doing specific, we use different terms in this case, but they're basically compulsions to get rid of the distress. It makes you feel better, but in the end, it makes symptoms worse. There's a couple differences, somewhat minute differences. In the end, the treatment we do for them is the same. Any acute anxiety disorder or OCD, we treat with exposure therapy. So sometimes you'll even hear people, hear professionals talk, here's the presentation. What would you label this as? Couple of ways, though, that you can help to identify the difference. With illness anxiety disorder, all of the concerns are around your health. I might have cancer. I might have AIDS. I might have hearing loss. Oh my, I might have a tumor. It's all the compulsions are related to that. It's body checking. It is, taking your temperature. It is researching on WebMD for hours on end. OCD, you are going to have generally a range of other presentations. If you have health concerns, am I healthy or not? You might also have concerns about being clean. You might also have concerns about inadvertently hurting someone or lining things up just right. There's usually several different categories with OCD, if not at that exact time, then over the course of a person's life. Generally, people are going through OCD for about 10 years before they get treatment. By the time they come in to see me, they're generally saying, look, this was my theme then, but then it was this, but now it's this. Illness anxiety disorder, it is always. Another nuanced difference is current fear versus future-oriented fear. So with illness anxiety disorder, the fear is usually more over, I have something. I currently have a tumor that is pressing on my pineal gland, is causing me to sleep all the time. I currently have undiagnosed Parkinson's, and I need to go get it checked and get it confirmed so I can get it treated. OCD health concerns are generally more future-oriented. Oh my gosh, what if I touch that doorknob and I have an open wound and I get AIDS from it, or I get cancer down the line? So basically, I have to do this thing to prevent a bad outcome in the future from happening. In the end, that makes it sound black and white. Sometimes there can be gray areas. You might have one primary area and a second area that's kind of stressful. You might have both present and future concerns. Luckily with this, though, in the end, from a therapy standpoint, I can't comment on the medication side, but at least from a therapy standpoint, the treatment would be similar.
Yeah, you were talking about the doorknob, and I was laughing because I always say there was this Rihanna song when I was growing up. It was like she sang about her car going from 0 to 60 in 3.5 seconds. And I'm like, yeah, I can go from touching a doorknob to planning my funeral in that same amount of time. Um,
Yeah.
but yeah, I think, with OCD, it just jumps out of control so quickly. I was laughing the other day. I ran over a bat with my car, and I was like, oh, that's
Oh,
unfortunate. But 3 years ago, I would have been like, oh no, my whole car has rabies and I can't put
hmm?
groceries in the car because then the groceries will get rabies and I'm going to have to go to a car wash, but then everything is going to be all over the car instead of just on the tires. And it just spirals so quickly, um, with OCD. And then I always say too, if I went in one of those scans that they check for like everything. You know what I'm talking about? It's super expensive. And if I went in there and they were like, here you go, here's your clean bill of health, my OCD wouldn't be like, oh yay, I'm never gonna bother you again. Thanks. It would be like, oh yeah, you didn't have anything, but now you probably got cancer from the radiation from that thing.
Right.
So it's always gonna be something else.
If OCD it will never be satisfied. Neither is illness anxiety disorder, by the way. So they go to 10 emergency rooms because you think you're having a heart attack or you have heart problems and tell you it's anxiety every time. You're still going back, you're still checking. So good question. Let's go down the line here. What about OCD staring, peripheral OCD? Yeah, I mean that's one that we come across here. It's kind of a broad term. Very treatable. What you have to do is identify what the purpose of the staring is. And I've worked with several of these cases, and the reason is often different. With the treatment that is done, you basically want to expose the person to the fear and prevent them from doing the compulsion. I've worked with people who have an urge to stare, or they say, oh my gosh, what if I stare at this person? And so they explicitly avoid looking at them. So the treatment might be to stare. I've worked with other people who it's the opposite. They stare, and the fear is if they look away from it, something bad's going to happen. So we have them avoid the eye contact. If they're staring and afraid something bad's going to happen, if they look away, we have to look away. If they're looking away because they think something bad will happen, if they stare, we have them stare. And it responds very similarly. It's kind of a nuanced thing that is, you don't hear about it as much in the media as you do with things like contamination, but treatment for it is exactly the same.
Yeah, I think too, and correct me if I'm wrong, but I think the staring is also compulsive in the sense, for me, I'm so hyper focused, or I was so hyper focused and so hyper fixated on things that, if I'm staring at the cashier or I'm staring at the waitress or waiter because I'm looking for contamination or like an open wound or a cut, right? So like I would inadvertently do that because I was scanning, but
Yes.
to the other person, it looks like I'm just, staring.
And we use the term staring OCD as the name of a subtype, but staring is often a common compulsion in all subtypes. So if anytime you're alerted to a threat, we call being hypervigilant, you're going to stare at it usually, and you might be staring at it to make sure it doesn't move, it doesn't endanger you. If there's a spider in front of you, stare at the spider to make sure it doesn't leap on you. Maybe we have you close your eyes in front of the proverbial spider and say, who knows what it's doing? Everyone is different, and it's all about identifying what those compulsions are and trying to prevent you from doing the compulsions and letting your brain learn that, oh, when I don't do the compulsions, I end up being okay. And every time we do that, we rewire your brain just a little bit. Do it over and over and over, it becomes less scary over time. Let's see. How do you deal with patients with OCD, with severe health anxiety, who have also had chronic illnesses like POTS and PANDAS, including very severe and frequent allergies for their entire lives? Wonderful question. And kind of a two-part. So I'll respond to their POTS, or PANDAS and allergies. So anytime somebody has what is called PANS or PANDAS, this is acute onset symptoms of OCD that generally occur from something like a viral infection, although it can be other things. The therapeutic treatment remains the same. That is still ERP. The really only different thing is that there are some additional medical interventions that can be done. So in those cases where it is identified that it could be, we do refer out for diagnosis of this to a medical professional, and there are certain techniques that they can use to identify if that's occurring, identifying some biomarkers in your body through different scans. And if it's determined that you do have it, they may be able to offer you some biological interventions and or injections for it. That's really on our end, the therapist side of things, it's just a referral. The treatment that we would do would be the same, but it would still effective in those cases. For other chronic illnesses that you have, like let's say you have severe allergies, and you are, this came up actually very recently in a case of mine. Let's say that you have, your OCD is around going into anaphylactic shock over touching peanuts, and you have a severe peanut allergy. Okay, well, what do you do? Well, what would your doctor recommend you're able to do? Everything that's done in ERP is going to be what we would ask somebody in your similar situation without OCD to do. In the case of a peanut allergy, there's varying degrees of severity. Some people, you just touch it, something happens. Other people, you have to ingest it. So if you're somebody who has a mild to moderate reaction, and that's only if you ingest it, and a doctor, a medical doctor tells you, you could hold a jar of peanuts and give it to your child because they love peanuts, and that would be okay. You may be asked to do exposures to hold a jar of peanuts. But we never are going to ask you to do something that would put you at medical risk, any kind of risk like that, so you would not be asked to ingest them. Well, what if allergy severe? Even getting a sprinkling of dust on it is cause for concern. Well, in those cases, what if you're not leaving your house because you're so afraid of it? Maybe the exposure is just to have you walk outside on a sidewalk and think, oh my gosh, what if a giant peanut ran into me right now and spread all over my body? It could be looking at a jar of peanuts online. It could be closing your eyes and imagining that you're touching or eating a peanut and your face is getting red and bloated. There's lots of different ways we can get creative. But we would never ask you to do something that would put you at any kind of legitimate risk of physical harm. It would be something that we would anticipate you would be able to do with your allergy, assuming that the OCD was not there at all. And there's other issues that are going on, like you have chronic pain, and an exposure involves going outside and walking. We could find a way to modify the exposure. Maybe instead of walking or running outside, you get to get driven around or get to drive around in your car with the windows down. We can get pretty darn creative with these to find ways to still help you while also taking into account any kind of physical complications or risks that may occur. Very good question there.
Got a lot of questions now. I
Oh,
like it.
yeah. Contamination and disgust. What if I step on a condom or a needle and track its contaminants into the house, bring in HIV, AIDS, or other diseases, my family catches it? There's a worry about that, but also a lot of disgust. Great question. So disgust is a subtype of contamination OCD. Contamination OCD generally falls under the umbrella of, I touch this and I'm going to get sick. I'm going to spread sickness. There is a feared outcome. So I will get sick and die. My family will get sick and die. I won't leave them with anything. I will be in physical pain for the rest of my life. Disgust is more of this feeling. It feels grody. If you pick up slime and sludge from a sewer, it's going to feel disgusting. This visceral bodily reaction. There might be a bit of a cleanliness component to it. If I don't wash my hands and get this off, I could get sick. But it's more of this visceral reaction. In that case, exposure and response prevention still works. You do see some modifications with it. Instead of asking you to sit there and imagine this feared outcome and seeing if it happens, we just ask you to sit there and kind of wait for either A, the feeling of disgust to go away, and for you to realize, oh, the feeling goes away, or B, and this is a weird one, it's hard to explain, you kind of have to experience, but for you to sit there and the anxiety doesn't change, but you learn to tolerate it better. And what this is like 10, 15 minutes in, you say, hey, I'm still at a 6 out of 10 anxiety, but I was 80% sure I wasn't going to be able to do this when we started. Now I'm pretty sure I can keep holding this, even though I'm just as anxious. And oddly enough, when that happens, you start to get less disgusted by it and less afraid that that disgust isn't going to go away over time. It's kind of a weird phenomenon. Um, and you're going to see more instances of that disgust feeling not going away as easily as the anxiety with other subtypes of OCD, which is where you get more into learning to tolerate it. The outcome still ends up being the same. Mild difference is because it has some different areas of brain activation. It can sometimes take a little longer for the exposure and response prevention process to take effect. But you still generally see it be helpful. It's just things to be aware of on the front end. It may present a little different in treatment. There are some cool emerging studies they're doing to try and find different ways of treating it, but nothing that is really kind of like solid.
I was gonna add to, I think again, because one of the first major things that hit me in my like childhood, well, going into high school was a fear of HIV. And I think that, it kind of plays back into that healthy level of concern too. Like, okay, well, if someone stepped on a needle, like there's a level of concern
Yes.
there. But for me, with my OCD, like my husband is a Marine, so we were stationed in San Diego, and there was always reports of needles on the ground and like things like that. And we were going to go to see the Padres play. And my brain's like, oh no, what am I going to do if I step on a needle? Right? How am I going to, I should look up if they've cleaned the street before we go and what would happen. Right. And it's like that. It's OCD rarely wants us to stay present. And so I think it's like jumping to worst case scenario and pulling yourself into like a future situation versus present. And I think, I try to remind myself too, like I never want to be like put in a box. So like there is that healthy level of concern. Like, yeah, that would be my husband's response is like that would be unfortunate. Because my OCD also latched on to like rodents and the diseases that they carry. And we're in New England now and there's mice everywhere. And one ran out from underneath us one day when we were walking, and my husband was like, oh gosh, that's unfortunate. And it is, right? Like it is this unfortunate thing, but my brain is like, oh no, and I have to pull myself back to the present because I find myself jumping to that future place in those moments.
Yep. Great addition there, Mackenzie. It is always about bringing yourself back to the present. Yep, this might happen in the future. We don't know. We don't know what's going to happen with this. We don't know what's going to happen with contamination. No clue. Can online therapy be beneficial for treatment of certain OCD subtypes? Yes. Not only can I speak to that clinically, but we've had research that's come out recently for those of you that are into that, showing that it's very effective. Clinically, I can tell you that it's going to vary. Generally, you're seeing it about the same. There are instances where it can be, we might recommend in person, and there are instances where I would actually recommend virtual over in person. In person is really good if you have somebody who's really distracted at home, like they have a million things going on around them. They're refusing to sit still. They've got 5 kids running around them who are making noise. They're constantly having to get up and out of their chair. They can't get away from it at home. Might make sense to go in person. Alternatively, let's say you have somebody who cannot go into their sister's bathroom at home. They cannot. Well, treatment involves doing exposures. If they come into your office, they might be able to go into your bathroom easily in your office. There's nothing they can do there. But or alternatively, let's say that they are afraid of walking out in California and stepping on needles. If they're inside your office, how are they going to do that? If they're on a phone with you in downtown walking on the sidewalk, in this case, a safe area where you're not going to have it happen, you're going to be able to evoke that fear more effectively and do more effective treatment. In general, you're going to get similar outcomes in both situations. But yeah, there are some times where you you might recommend one versus the other. Really just depends.
I loved being able to do ERP therapy from my phone because of exactly what you said. I mean, you get to take your therapist with you, and that was a, like a support system, but also like an accountability thing. And I also love how easy it is for loved ones to join therapy sessions if you give them, the opportunity to, and then they get to, participate in exposures or understand, what they can do to help, or, it gives everyone, um, I guess like again, it holds everyone accountable, whereas you might not be able to get everyone's schedule together to get to a therapist's office. And, it just, for ERP therapy, I feel like it makes everything so much better, in my opinion, and for my journey, because it's so good to be mobile and to be able to do that.
I like how you mentioned the people coming from different locations. I've done treatment where the patient's at their home, but then their partner or their parent is off in Nevada somewhere, and they call in from where they're at so that they can be involved in the treatment and learning as well. So it really facilitates more familial engagement, which is it's important for everyone, especially for children and adolescents, but I would argue for everyone involved. The more your family knows what's going on, the more that they're going to know how to respond to your OCD, because your family can easily make things worse by feeding the OCD. Hey, honey, do you think I'm going to get sick from walking on the sidewalk? No, you're not going to get sick. You're fine. Oh, phew. Are you sure? It keeps the cycle going, and the more that they know not to do that, although it might be frustrating in the moment, the more effective treatment's going to be.
Yeah, that was what I always said to, I'm like, you learn, your loved ones get to learn what you need versus what your OCD wants. And that was always, I remember sitting down, and my therapist was like, "Oh, how's everything going?" And I was like, "Great." And my husband was like, "Really?" Because, and I think sometimes we're unreliable narrators in the beginning. And so it's a good opportunity to like get it all on the table.
Yeah, and you have people come and say everything's fine. Their loved one will look at them. What about the 3 hours you spent scrubbing yourself clean? Oh yeah, that. So I really do like bringing the family in for those reasons too. Does ADHD complicate OCD treatment, and how do you address this? Depends on the severity. ADHD, there are broad symptoms of hyperactivity and inattention. Really, the biggest impediments you're going to see is, and especially you're going to see it more in the younger kids, is are they able to sit long enough to do something? Uh, it is totally doable with people with ADHD. Very often, usually I'd say we don't really have to make major accommodations. For the younger kids who their inattention and hyperactivity really starts to lead to irritability and distress after 30, 25, 30 minutes, you may have to make some adjustments. Typical adjustments in these cases are allowing more breaks in therapy and in between exposures, and or shortening session times to really increase compliance and their willingness to come in. What you don't want to do is, when I've worked in residential treatment centers before, I would have our patients do 8 hours straight exposures. I mean, to the degree they'd be willing to, and some would. It'd be a full day of exposure, exposure, exposure. You don't want to spend an hour doing that with a kid who hates you after 20 minutes and refuses to ever come back. So if they need a break here and there, again, let them readjust. In more severe cases, you might want to refer out for medication management first to help get symptoms to a more moderate level and stability, and then re-engage back in treatment, because it does take at least a moderate degree of focus to engage in. If you are forgetting things with ADHD, you can bring in family members to help them remember to do assignments. There's other tricks you can use, like setting an alarm to go off every day. This is when I'm going to do my exposures, so you don't forget. Sticking Post-it notes up around the house, stuff like that. On to the next one. What do you do for the thought that you're never going to get better from OCD? Well, this kind of comes back to what I was saying before. Is first you want to identify, before I was using the term diagnosis, but in this case, the nature of the thought. I've worked with people who have severe symptoms of depression where they're like, I'm never, it's less a worry, it's more, I'm never going to get better from OCD. What's the point of living? And that's where we do some cognitive intervention. We do some work with them. Hey, you have a lot to live for. And we help them realize what they have to live for, what they have to fight for. Treatment's very different if it's an OCD fear. I've had people's OCD be about OCD. So what if my OCD never goes away and I never get better and I'm out on the street and I lose my job and I'm just anxious all the time forever and ever and ever and ever and ever? In that case, the fear is having OCD and the exposure would be, yeah, what if you never get better? Let's go into that really in depth. Let's read about people who have never gotten better from OCD. And the great thing is that responds just as well. But this is where you have to identify what's going on, because if it is an OCD thought, I can't tell you, oh, it's going to be okay. You have so much to live for, because that's reinforcing the OCD without going into the reason why too much in this talk. Basically, you cannot give the OCD what it wants. You cannot feed the fear. You have to let the fear just be there. So identifying kind of the nature of the thought is important at first, and then you know how to address it. Regardless of what the background of the thought is, though, there are good treatments out there for both.
I think too, oh, sorry, did I cut you off?
Okay.
I think too that it's the scariest place to be is in that OCD pit. And, a lot of people ask me if I'm afraid of relapsing. And I always say too, like, I don't think I ever relapsed because I just lived 28 years in pure dumpster fire chaos. And now at 32, I've had these years of recovery. And of course, I'm afraid to relapse. That's a normal, thing. And the idea of going back there scares me. But I think again, it's where you really dig in and lean into the value versus fear. And if I spend all the time in my where I'm supposed to be present worrying about a what if, well, that's a really good indicator that OCD has, showed up. And I think what ERP therapy has taught me is that if and when that happens, I can handle it when I get there. I also think too, like when we go into ERP therapy, like you never start back over either because you can't unlearn what you've learned.
Right.
But yeah, I think that the only other thing I would say about that is we can have all the resources and all the support, but until we decide to kind of push ourselves over that proverbial threshold and do those hard things, I mean, that was really where all the progress started for me. And I kind of realized the only thing scarier than my OCD was where I was living in that moment. So
Yeah. It's the lifestyle change. You learn what you learn in therapy. If you implement going forward, you will be better at treating OCD than most of the psychologists that I have worked with in my career. How does ERP work with mental compulsions where there isn't a physical manifestation of the compulsion that one can prevent? Great question. 90% the same. You're just preventing the mental compulsion instead of the physical. So with hand washing, you're preventing yourself from hand washing. With mental compulsions, if you're counting to seven times to feel better, you don't do it. Now, I realize some of you are saying, wait, that doesn't work. Just don't do it. How do you do that? It's like if I tell you not to think about a pink elephant, you're going to think about a pink elephant. The more you do it, you do gain more of a degree of control over the mental compulsions, and you can start to kind of stop preventing some of them from coming in. But to a degree, some mental compulsions are more likely to slip through. Sometimes the brain is just going to do what it's going to do. Without you even realizing it, your brain might say, nope, you're okay. Nothing bad's going to happen. Well, credit. I just did a compulsion. I didn't even need to. The good news is when you're doing an exposure, this doesn't necessarily ruin the exposure. You just have to undo it. Different places use different terms for this. We call them response prevention messages. This is something where you just bring yourself back to the fear. So let's say you're afraid that by touching a doorknob, I'm going to get AIDS and die. And you, without even trying, your brain says, no, I remember from science class, AIDS doesn't carry on a doorknob. It lasts for like 5 seconds on liquid on surface and then dissipates. Well, counter that thought. What if this is a new strain? What if somebody touched that doorknob right before I touched it and that was enough for the AIDS virus to transfer? Make a statement to bring yourself back to the anxiety. And if you do it fast enough, it does allow you to kind of counteract the mental compulsion. It's kind of like if you inadvertently force you go and wash your hands, you're like, man, I shouldn't have done that. You shove your hands back in dirt immediately to get them dirty again and bring yourself back to doing the exposure. It's kind of the same equivalent of that. And as time goes on, you will gain more experience just not even having doing the mental compulsions in the first place.
Yeah, mental compulsions are sneaky because the only person to hold you accountable is yourself, really. And I think
Yes.
that I try really hard. Sometimes it's super easy to pull yourself back to the present, and that's kind of what I do to keep, to live with that mental compulsion that's going on. But like sometimes I have to say, like, what do I see? What do I smell? What do I hear? Like to pull myself back into what I was doing before I checked out. But they do happen, really quickly. And I think it's just, okay, that happened. Now what am I going to do? You know?
And I like how you say the only person who holds you accountable is you. If I'm doing an exposure and you have a physical compulsion to tap your fingers together, I can see it. And I can say, hey, don't do that. I mean, I say it more nicely than that, but I can identify. If you're doing mental compulsions, I can't necessarily tell. And I've worked with people who have made little progress, and I'm like, man, let's try and figure out what's going on. And a dozen sessions in, they're like, look, I got to be honest with you. I've been telling myself everything's okay the entire time I've been doing all of these exposures. And it's like, so you have to be willing coming into this, if you have those mental compulsions, to not only identify them, but be honest with yourself and your therapist about what they are so that you guys can work to begin countering them together. I think probably have time for one more. Let me pull up the thing here. How do you handle perfection OCD? So perfection OCD is this other subtype where kind of this broad term where people have to do things that are perfect. Things have to be lined up perfect. I have to write with perfect flow in my cursive. For those of you who don't know what cursive is, it's the thing older people did before computers became a thing. Everyone is different. The exposures are going to be different for every single person. In general, it is to have you do it imperfectly. And the degree of imperfection is going to depend on how hard it is. So if you line up all of your, like the portraits behind me, I might have you go and tilt one 10 degrees to make it not perfect. And that might be a little hard. Later on in treatment, I might have you tilt it 87 degrees and make it be really, really just off and looking weird. Again, it'll be specific for everyone, but the general idea behind it is do things in an imperfect way, sit there and stare at it until you're like, this is starting to get kind of boring.
I was trying to see quickly if, oh, it's 5:59, but
If
some,
we can get one, I don't know kind of what our time limit is exactly here.
well, I was just gonna say there was this one about so like how should I handle OCD related fears when they stem from a real psychological issue? I'm sorry, physiological issue. So like you fear not breathing through your mouth and you're not getting enough air through your nose, but at the same time I have anxiety about mouth breathing. I was just gonna say, I feel like, and correct me if I'm wrong, Dr. Gibbs, but um OCD is always gonna find validity wherever you
Yeah.
try to let it. And so like somebody asked a question about driving OCD. Well, I'm a horrible driver. So my OCD is like, well, of course you hit someone because you're a horrible driver. And that's, it's trying to find that validity. So like, oh, I have this pain in my arm. Well, OCD. I'm like, if I have a headache and I Google it and it says there's a 0.0005% chance you have 5 hours to live and you're gonna die from brain cancer. My OCD is like, see, I told you. But it jumps over that 99 point whatever percent that everything is fine. So
I love that. Maybe you are a bad driver. Okay. I still want you to sit with the fear that maybe you hit someone. Are you such a, are you, like, this goes back to what we talked about in the beginning of, would someone else in your position without OCD be able to do this? If you're such a bad driver that the state has rescinded your license, that's one thing. But do you have a license? Are you legally allowed to drive? Okay. Maybe you're not that good. You're allowed to drive. I might have you drive because there are a lot of bad drivers out there. Maybe you do have a pain in your shoulder. Okay. Would you can also ask yourself, is this OCD by how much I'm trying to address it and how repeatedly I'm doing the compulsions? Is it, if you have a sharp pain, is it normal to think, oh, hey, I wonder what that is? If it occurs often enough, is it normal to go to the doctor? Depending on severity, sure. If you go to 10 different doctors because they're not giving you the answer you want, no. It might be a legitimate thing that you can't figure out, but at some point you got to realize it might be more of an anxiety-based thing. And interestingly enough, anxiety can manifest as physical pain. So if you accept that and treat the OCD, the physical pain might go away.
yeah, fighting a battle in your head can definitely have some physical symptoms.
Very much so.
That was fun.
Well, it was. Great questions too, guys. Fantastic questions.
Yeah, thank you guys so much. I oh, I think that it's 6 o'clock, yeah. So um that was, thank you, Dr. Gibbs, for including me, and I learned a lot today as well. So
And I appreciate you being here too and providing your kind of personal experience on these things. It's one thing to know how to treat it, but I really appreciate when people with the severe lived experiences are able to share their uh, what they've been through. Because that is there's only so much that you can't even treating it, you can't fully know what it's like and the pain and suffering unless you've had it. And I think that being able to share that in these talks brings a lot.
well, I'm always happy to help other people feel less alone and more understood. And ERP therapy was life-changing for me, so I will always advocate for it. All right, thank you guys so much.
Everyone.
Bye, everyone.